Hi, we're here for the spotlight session on lung cancer. I'm here with Dr. Jason Porter and Dr. Chris Jackson. Dr. Porter, you want to say hi?
Hello, everybody. I'm Jason Porter from West Cancer Center and Research Institute in Memphis, Tennessee, thoracic medical oncologist.
And hello, everyone. I'm Chris Jackson. I am a academic primary care physician at Regional One Health, associated with University of Tennessee Health Science Center here in Memphis as well.
Thanks. And I'm Matt Smeltzer. I'm an epidemiologist at the University of Memphis, specializing in lung cancer. We're going to talk about lung cancer today, and it's the leading cause of cancer death in the United States. And although smoking poses the greatest risk for lung cancer, there are many other important risk factors such as radon exposure, air pollution, and unknown factors that cause many individuals to be diagnosed with lung cancer every year. Screening of high risk individuals poses probably the best opportunity to diagnose lung cancer early and save lives. But we've seen in some previous sessions that screening uptake for those who are eligible is quite low in the United States, and eligibility criteria are somewhat stringent, which we're going to get a chance to talk about today. We're located here in the Mid-South United States, and for multiple reasons, it's considered an epicenter for uh, health issues, including heart disease, diabetes, stroke, obesity, and more. We're also right in the um, a real hotbed for lung cancer incidence and mortality. The American Cancer Society recently recommended changes to the screening guidelines for lung cancer, lowering the number of pack years of smoking exposure necessary for screening and modifying the quit duration requirements. And we know that smoking is not the whole story on lung cancer. There's a lot of other risk factors, a lot of other factors to consider. But we have seen some changing epidemiology over the years. So my first question uh, to you, Dr. Porter, how has the changing epidemiology of lung cancer in recent years affected your practice, and what implications does that have for primary care?
Over recent years, I feel like the incidence and the demographic makeup of the patients that I'm seeing has changed. I'm seeing older patients as people are living longer in general. I see lung cancer in older patients. Historically, lung cancer is mostly diagnosed in older patients, but of course, we have our populations of patients who are much younger, those with oncogene-driven tumors. And then even I have population of patients that are younger without oncogene-driven tumors. So I'm starting to see things, never smokers with lung cancer. We have more organ transplant. I have many patients on immunosuppressive mechanisms for rheumatoid arthritis and other diseases that are then putting patients at risk for developing cancers. Also, we're right here in the Mississippi River area and histo and granulomatous disease. So we know that there can be false positive scans but we sometimes have, false positive scans, but then sometimes we have false negatives in patients as even never smokers and patients who had immunosuppression for various reasons where they had histo, which the chronic inflammation may have translated into diseases like lung cancer. So with all of these different things going on, I'm excited about the screening criteria, but I just told you about very young patients with lung cancer, and then also patients with immunosuppression with lung cancer for whom they don't meet the screening criteria. So with this change in demographic, we really need to revisit who we're screening.
Dr. Jackson, from your perspective, what are you seeing?
Similar to Dr. Porter, definitely a wide spread of patients with lung cancer. And based off his comments, it really has me questioning, like, how can we better personalize the decision around lung cancer screening as non-smokers, younger patients, more organ transplant patients are having this disease? Can we come up with better risk prediction tools? I think the other thing that I am seeing on the opposite side is kind of the survivorship piece. So, like when I was a resident, somebody having stage 4 lung cancer was akin to a death sentence. And now, with the advent of immunotherapies and all the advances in chemo, patients, even with extensive stage small cell lung cancer, are now living 1, 2, 3, 4 years. And so, as a result of that, now in primary care, I am seeing these patients afterwards and thinking about, secondary cancer screenings that they need, the mammograms, the colonoscopies, but also that chronic disease management piece that's so important. Many of them will still end up dying of cardiovascular disease. And how can we, risk modify for these patients in a way that we haven't had to think of before, because we often thought, well, they have this cancer, so, all the concerns around using statins or other risk reducing medicines kind of go away. As they're living longer, it's kind of making us rethink that calculus a little bit.
Just to piggyback on that, Dr. Jackson, also another thing that it makes me think about is when we start doing some of the risk reducing things like aspirin, which is technically an anti-inflammatory, how does that impact outcomes in patients who are getting immune checkpoint inhibitors? Does it make a difference at all? It's a very low dose of aspirin, we know usually, so probably not that much. But then we start to think about the cycle. We got patients surviving, and now we're doing things to help improve their survival, but are those things going to impact their response to our therapies that we're using? It really can get a little bit overwhelming to think about, but it's nice to be able to have these conversations about patients that we couldn't have this conversation before.
Absolutely. Absolutely. So many unanswered questions. And I think, now is the right time to be able to ask those research questions and see if we can advance or think about more what survivorship care should look like for the patient with lung cancer. And is it the same in small cell versus squamous cell versus adeno, or should it be different? Or are there risk mitigation strategies that have been left untapped?
Very excellent points for sure. What about the stigma and bias? How does that impact your interactions and the ability to give good care and get people screened for lung cancer in our region?
I'll take this one first. Certainly, I have a lot of patients who smoke, and I think in having that, some of them feel that, well, doesn't matter if I get this screening or not, I'm gonna die with something anyway. And if I die with, this lung cancer, that's fine. And so I find myself trying to untangle whatever their health related behavior was from their feelings of whether or not they deserve or not, to get this testing. I kind of say, like, sure, you might have smoked for multiple years, but that doesn't mean, one, you deserve lung cancer, and two, it certainly doesn't mean that if we can catch it early and intervene where you don't have problems from it, that we shouldn't. And I think for some of them, kind of letting go of that stigma, I think becomes, very important. One thing that Dr. Porter has brought up before, and I think is so true, is also just in the name. When I ask my patients about breast cancer screening, I can just simply say, have you had mammography? Or when I ask my patients about colon cancer screening, I don't necessarily have to call it that. I say, have you had your colonoscopy or done your stool-based tests? Can we simply change the nomenclature and say, like, have you had the CT of your chest? And, of course, we can say why we're doing it, but I think maybe taking it from just a pure, like, you are getting lung cancer screening, we are doing a risk assessment for lung cancer. And I do think that nomenclature change is important in how people perceive it.
Yeah, I can't take credit for it. I heard another oncologist talking, and they called it lung health screening. And if you call it lung cancer screening, I think the kind of underlying tone is, oh, they want to find my lung cancer. Oh, no, we want to make sure that you don't have it, and so that we treat it early. And so calling it a lung health screening, a caution against calling it, just say, have you had your CT of your chest? Because some patients don't know the difference between an X-ray, CT, and MRI. And so then they may get confused and think, oh yeah, they scanned my chest, but they don't really know the difference in the modality. So, but to just say, if everybody agrees, hey, let's call it lung health screening, that's what it is from now on. And then when we talk to patients about it, they understand what we mean. And when they go in for it at the radiology center or whatever they're having their imaging done, if they call it lung health screening, then they'll be able to come back and say, have you had your lung health screening? Oh yeah, I remember that lady or that person at the radiology center told me that's what I was doing.
Yeah, I think that's great. We saw in a previous session that the uptake of screening for eligible individuals is around 5% in the United States. Um, what do you think are some other factors that may contribute to low uptake? And I know we've talked about some of them. Is there anything else to add there?
I'll start. I think that there's certainly some, mm, for lack of a better word, getting a little bit dizzy with all the changes and what the criteria look like. I remember when it was in the 60s, then 55, then 50. It was 30 pack years. Now it's 20 pack years, 15-year quit. Now not a lot of those changes, I think, for the busy primary care doctor can be a lot, particularly when we're not just screening for lung cancer, but we're doing all other sorts of recommendations around cancer screening. I think, too, I have had some issues insurance-wise that as these changes have occurred and insurance companies haven't quite codified them yet into how they assess for eligibility to get these services paid for. I've had some patients where I remember one was 49 and a half when I ordered the test, and it came back rejected because they said, well, the patient's not 50 yet. And so I had to call and say, well, can you just schedule the test after he turns 50? And then automatically it was approved. Now, I recognize that, I'm willing to go and make those extra calls, but I also have the bandwidth to be able to do that. What about the busy primary care doctor that does not have that, and, that being a hurdle, and then all of a sudden now that's missed, and then we go a year or a couple of years and it's not done. So I do think that, that is out there. And then I think also just how much is it heard about in the lay press, I think is a big thing too. Most of my patients, when they come and talk to me about cancer screening, will inevitably talk to me about breast cancer screening. They'll talk to me about colon cancer screening. And then, particularly me taking care of a lot of Black men in clinic, they will come and talk to me about prostate cancer screening. And I do think there's a relationship between what they choose to come and engage and talk about in clinic and what they're coming into contact with in social media or lay press, et cetera.
Yeah, I agree with that. I was going to the American Society of Clinical Oncology last year, rolling into ASCO in Chicago, billboard with a CT scan and a patient having their lung health screening. And I imagine by now that those would be all over the place. They should be everywhere because people smoke everywhere. And I saw it, but I'm going to tell you what, if I hadn't been paying attention, I would have missed it. I don't know if it's certain cities have limits on the height of billboards and certain things, so it could have been just that's their height limit, but it wasn't a big tall billboard and it was kind of nested in between a couple of buildings, but I saw it and I got really excited. And I know that we have really big, tall billboards here in the city, and we could put that up anywhere. Have you had your lung health screening? It should be everywhere. That way, the lay press, it's normalized. And another thing that I always mention, just from Dr. Jackson's comments, how complex it is to remember what the criteria are, what the guidelines are. It should be generalized. It should be risk stratified and generalized. Everybody gets it, but everybody doesn't need it as often. And and so that would make it a lot easier. In some ways, it would make it a little bit more complicated, but If we have centers of excellence that are focusing on lung health screening, then when a primary care physician makes a referral, that once the patient's in that system, then it kind of goes on autopilot, just like colonoscopy. I'm sure that wasn't easy at first. 1 year, 3 year, 5 years, 10 years, who comes back when? But we got it figured out. And now, once that intervention has been done, the recommendation for when to come back for another is there. And we see it on CT scan reports already. You should have a repeat scan in 6 months or 3 months or 1 year. And then we know when. And the risk for that patient should be available to the radiologist reading the scan. When we order the test, we should say, this is a smoker or not a smoker. This is a person with immune suppression or not. We need to make a questionnaire that we answer every time we're screening patients so that we can help risk stratify and help that radiologist really say where this patient needs to be as far as follow-up goes. The other thing that I have to mention is that I have, colleagues in different parts of the workforce from, who are taking care of these patients, different areas, and they say, how are you doing with lung cancer screening? And I think about it and I go, well, I actually treat lung cancer. So you're asking the wrong person about how they're doing with lung cancer screening. We need to really support primary care in helping to drive this. As an oncologist, I can say, yes, I agree 150%. But when I'm in clinic taking care of patients who are actually dying from this disease because of lack of screening or late discovery of disease, I honestly don't have a lot of time to go out and do the actual screening. So that is not a function for an oncologist any more than the colon cancer physician or the GI oncologist is doing or participating in a colonoscopy. The primary care doctors recommend that the colonoscopy is done. And if that patient has a diagnosis, they make it to the GI oncologist. In lung cancer, there's thoracic oncologists out here with these screening programs. You don't encounter most other people. On a screening program, if you say, oh, we screened 500 patients this year, highly inadequate. That's not enough. That means that that's how many patients that we saw, that we got screened in an already cancer center. No, that's inadequate. Primary care doctors are seeing thousands of patients, and that is where the numbers are. That is where the focus needs to be on building these screening programs. A thoracic oncologist, you may appreciate the notoriety, but it's not my responsibility. And I don't have contact and access to enough people to really be effective in building these screening programs. That's why I'm so grateful for the opportunities, programs and platforms like this where we can engage with primary care and they can talk back to us and tell us things that we as oncologists need to be doing to improve the care of our patients, but then to help and support them in screening efforts.
One thing I'll add is that I think sometimes we're looking for these grand solutions from elsewhere, but there are examples that we can draw from. So I think, for example, in the VA system, they have something called the Multidisciplinary Thoracic Oncology Clinic, or MTOC, which essentially functions like Dr. Porter is mentioning, where I'm a primary care doctor in that system. I can order a CT scan. I can see some abnormality or something on the CT scan, or I don't, and this patient's high risk, and I refer them to this program. And then they kind of take over, help with saying, like, okay, we have a group that's meeting monthly that's looking over everybody in this program. When should they, get a repeat scan? Or, oh, this needs to be biopsied. Is it pulmonary? Is it cardiothoracic surgery? And that's within the VA system. And so even right here in our backyard, there are probably opportunities for us to learn and figure out, okay, how can that be generalized in a way where everybody has access to it? So that's one. And then what I would love to see is the engagement of the EMR and other things to be able to say, if I have my clinic and I have, great ancillary support and things, how much can I automate this? Like having somebody that's going looking through, making sure, okay, we're getting all those follow-up things done so that it doesn't just reside in the appointment. I think I'd share with Dr. Porter a very interesting paper that showed that if you come to a primary care clinic in the afternoon, like particularly later afternoon, you're less likely to get cancer screening. Why? Probably because that primary care doctor's seen how many patients before that. And so when we get busy in primary care, I'll be honest, one of the things that goes away is probably the cancer screening. Not because it's not important, but usually because there's the whole other acute symptoms, chronic diseases we're trying to optimize. And so to me, one thing that suggests is we need to be able to think about that inter-visit care and in what ways can we optimize cancer screening in the inter-visit space so that it doesn't just reside at the point of I'm talking to that patient.
I think that is such a great idea. Could you imagine, number one, when somebody, a representative from my center, calls one of my patients and says, hey, Dr. Porter wanted me to say or tell you, Dr. Porter wanted you to know, they feel connected. And
Mhm.
if the patient's, hey, Dr. Jackson, asking me to call you and go over these quick few questions with you. Have you done this? Have you done this? Have you done this? Oh, no, then let us get that set up for you and, move on to the next patient. Great idea. I think that's an absolutely fantastic idea. And then it makes that patient feel more connected to you. You come back to the office, they come to see you. Oh, thank you so much for calling to check on me.
Mhm.
And there's a deeper connection with you as a provider. I That's a great idea.
Yeah, I love that, and I love the dynamic between the oncologist and primary care. And I think you all are describing how that can look and how that can flow. Can we dive into that a little bit more? Do you have some examples of successful collaborations between oncology and primary care and lung?
No, Dr. Porter and I have taken care of a few patients together, but one that comes to my mind is she's probably in her late 60s or so. It's a patient I saw in clinic, or actually, I take that back. It was a patient where I got called with an abnormal radiology report saying that the patient had a suspicious looking mass for lung cancer. Never met the patient before, called and talked to her. Was very scared, but of course, knew Dr. Porter. I gave him a call, was able to give a quick sign out about the patient. Hey, this is what I'm worried about. This is a concern. This is what it looks like. I leveraged the doximity to be able to send something HIPAA compliant to his fax and things. And within a week or so, patient got there, had biopsy, found out they had a squamous cell carcinoma, was able to go and get lobectomy. And that patient has been living without lung cancer now for a couple of years. Had another patient of mine who is unfortunately has paraplegia and things, and end up having a stage 4 lung cancer kind of found incidentally, and came to see me in the office, did the same thing, called, gave a quick follow-up. Next thing I know, a couple of weeks later, in there with Dr. Porter, getting immunotherapy and things, and the person's still living.
Yeah,
And
and I will say that was extensive stage small cell lung cancer, and that was
thank you.
about 4 years ago, and he's still with us.
But I think that collaboration one looks like one, I need to know what things, Dr. Porter needs to know to be able to move things along. So, you know, knowing smoking status or not, other risk factors for lung cancer, how concerning is this mass? What can I tell him real quickly in a sign out? Because both he and I are very busy in clinic, seeing patients. Or, once the diagnosis is there, kind of having that, interplay of, oh, this is what I'm worried about, or I know that you recently just started this immunotherapy, and I know there's a lot of immunotherapy-based side effects. Is what I'm talking to them about today something that looks like that, or should I be thinking something completely different? So I think it's having good sign out like that, you know, open, communication, And I think just making sure that um, as much as possible, we try to speak with a unified voice. And so, I never try to overpromise a patient something. I always say, I'm going to send you to my colleague and friend, Dr. Porter, where you're going to get an evaluation. I'm not going to tell you what treatment he may or may not do. You're going for an evaluation, and no different than when he's referred patients to me. You need to see a primary care doctor because I'm here to help with the lung cancer, but you have other things now that need to be addressed, and I want you to go and I want you to get that evaluation. And Dr. Jackson will treat and do the things that he thinks are necessary. So those are a couple of stories of wonderful collaborations. And again, when you just know each other well enough, it gets real easy to be able to say, like, hey, I'm worried about this person. Can you get them in? And no differently, if Dr. Porter called me and said, hey, I'm worried about somebody, I'd probably be willing to move heaven and earth, try to get them in, try to figure out what's going on.
Right. And I think that a lot of times we use some of the regular avenues to try to connect, and do things, and that's great. But when it's not working, I don't think there's any physician that you could call who you could tell that you are concerned about something that, that they okay, there's probably some, but not usually, that you can call and say, I'm concerned about this thing or that thing, that they wouldn't try to figure out a way to see the patient as quickly as possible. And there have been times definitely with primary care physicians, things like survivorship, patients who are now surviving peripheral neuropathy, especially with our chemotherapy patients in lung cancer, haven't had platinum. There's also immune mediated neuropathy too, which is less well described and not spoken about that often, but it can happen. But when I have these issues, adrenal insufficiency with either a primary care physician or endocrinologist, being able to keep a multidisciplinary team together. And even if they don't see the patient, maybe they can give me some insight and some recommendations. And so calling back to the primary care doctors like Dr. Jackson has been oftentimes the way that I'm able to get through my clinic, because I have a problem and it's bigger than I have the insight for at that particular moment. I may be overwhelmed knowing that the next patient that I see has progression of disease or had just gotten out of the hospital with a complication of therapy that I'm going to have to accept the responsibility for and say, yes, what I did to you is the problem, and I'm sorry. And so I may be thinking about all of that, and then I have this patient with diabetes and uncontrolled diabetes that I'm about to give 12 milligrams of dexamethasone before their chemotherapy, and I got to do something. Let me just call Dr. Jackson. Let me call, this person's primary care doctor and say, hey, this is where we are. Need your help with this management, and it makes it a lot better. The other thing is end of life. Where that patient may have been following with that primary care physician for a long time, and they just met me 6 months to a year ago, and we unfortunately didn't have a great response to therapy. And so we're at a point of transition in the goals of care. And I'm going to have this discussion with somebody. But there's this primary care doctor that's been there not only for this patient, but that patient's mom or maybe their child, and so they have a much more well-established relationship. So it may be easier for that person to talk to the patient. And so judging that, engaging and deciding who really should lead this conversation. Maybe I call Dr. Jackson and say, hey, Miss X is not doing well. Let's talk to them together, and I think we don't do enough of that. There are definitely opportunities where we can increase that, but when you're very busy, it makes it hard. But this is what you signed up for. And it's very important that you go the extra step, and these conversations remind me to continue to do that. So it's something that those collaborations can really change the way patients experience the cancer and the consequences or the benefits of the therapy. So I think all very important things to remember.
I think those are excellent points and excellent description of how primary care and oncology can work together to do the best for your patients. And it's an exciting time in lung cancer in a lot of from a lot of aspects. We've got some of the best therapies we've ever had, some of the best surgery we've ever had in lung cancer. And so I think the future looks bright, and it's exciting to hear how hard the two of you are working to make sure every patient gets the very best. And so we really appreciate hearing that insight. Any closing remarks or anything else we want to convey to the audience tonight?
I will say, since Dr. Jackson mentioned some of the various screenings that we do in these patients, that in primary care offices, a checklist that includes those relevant screenings and calls them by the appropriate names, and just a slip of paper that you hand in at check-in that can be entered into the EMR. They've had these things, they haven't had these things. And then as a part of the documentation, with the way these EMRs are designed now, that can filter into the note and be included as a part of the actual documentation for those patients. And if we standardize that everywhere, then it's included in all of the documents. And so just say, I saw a patient who needed a primary care physician, and they've answered the questionnaire, and then I refer them to primary, and primary sees, oh, this patient that came, from Jason had a lung health screening and a diagnosis of lung cancer, but they've never had a colonoscopy. And then the whole list. And as a nation, why don't we just agree to what our list is and say, this is the list? Right now, this is the list. So what is the list? Anybody watching, anybody listening, tell us what the list is. We know what it is, but let's agree and come to a consensus on what the list is and start talking about that list and increase the lung health screening visibility, and make sure that we include that in the discussion. And we really got to work with the payers, the insurance companies, and work together from primary care to oncology to establish what that list is for cancer screening, and really publicize it and generalize it so that it's just table conversation. Oh, the list is 6 things, right? So your list, did you do all 6 of them? Yay or nay? What did you miss? Why did you miss it? And then it's a really easy conversation to have. What is the list? We got to start. We need a list.
No, I totally agree. What I would add is the screening conversations can be revisited. I can tell you there are many patients I've taken care of that sometimes have said no to doing some sort of screening tests, and then follow up at another visit, and then maybe they've had time to think about it or change their mind. And so I would just encourage my fellow primary care colleagues, don't let an initial no turn you off to asking about it again, because it is, life-saving. In that one case I described, being able to find that cancer early, and patient only needed surgery, didn't even need chemo. Again, a lot of benefit to that. So revisit screening early and often with patients. You know, I think it's also my job in primary care to prepare them for the different roads. Dr. Porter kind of talked about complexity. And so I always like to say that, most of our screening tests, there's kind of 3 different ways it can go. It can be, quote, completely negative, nothing, and we still need to screen because the risk that got you to doing that screening didn't just go away with one test. So, we still need to screen. Or we might get some sort of inconclusive result, false positive, other things that, we will have to navigate through, or we find something that's super concerning. And so kind of preparing people that we can travel one of 3 roads, I think, is very important. And then the last thing that for me has been important with all of my, cancer screening, and particularly with lung cancer, is really engaging what their goals of care are in the survivorship space. As more people are living longer because of all these advances in treatment, I've really had to shift my focus and just say, well, we might still actually need to treat that dyslipidemia, or they might need that aspirin if other risk factors and things are there. And so I think sometimes there can be they survived the cancer and we don't really think about all the other things. I do think that it's important at least to have a discussion with that patient of their individual goals. Again, being thankful that things worked for the lung cancer, but making sure that we kind of address the other things. If we can move the needle on those three things, then I think that will do a lot of great care for our patients with lung cancer.
Well, thank you, Dr. Jackson. Thank you, Dr. Porter, for your incredible insights and the great discussion tonight. And I'd like to thank our audience for your attention. We appreciate you spending some time with us.